What's the most powerful sentence someone in emotional pain can hear?
Acknowledge. I can hear and see that you've got a lot of emotional pain. I can hear things are really hard for you. So acknowledging, not judging it, not giving any rider to, you really shouldn't be feeling this bad about it. Really acknowledging and accepting. You don't want to dismiss or minimize the emotion, even though you may think the person being a bit dramatic or whatever, you don't understand from their point of view why they are in such emotional pain. So accept it as they're telling you, acknowledge it to them, and let them know that you want to help. They need to be given hope.
What question do you wish someone had asked you during your depression period?
How can I help you? What can I do to help you? Is
Mm.
there someone I can get to help you? If I can't do it, is there someone you'd like me to find? Don't ask too many questions. Sometimes when you're depressed, whatever question the person gives you, you'll see it negatively. You have these special little antennae and you'll interpret it as them judging you or thinking, if they ask a question, why or what or when, you think, oh, they're judging me, especially asking why. Probably better rather than what question do you wish someone had asked me, it's probably more of what statement they gave me, which is, I'm here with you. I can see that you're not traveling very well now. I'm pretty sure it will get better. There's a lot known about this. Other people have had this low mood or this distress, and many, many people get through it. And I'm here to help you and to seek the best help for you.
What is one mental health myth you wish you could erase from society forever?
I think that people with mental illness are weak people, that they've made bad choices. They've chosen to be soft or they've chosen to be, feeling sorry for themselves, or with drug and alcohol, they've chosen, a silly path, made bad decisions. It's an illness like any other illness. And most people are not to blame at all for their mental illness.
And the last one, what is one thing families often get wrong when supporting someone experiencing mental distress?
Being judgmental, saying, come on, I've been such a good parent to you. I've been with such a good family. You're so lucky. This is the best family in the street. You've got, we've got a swimming pool and no one else has, or whatever. Making the person feel even worse, you're not, the person isn't being negative because they want to be. They dash well wish they could be better, but at this moment they haven't got the skills or the wherewithal to think differently, to act differently. So again, it's that acceptance, darling. I hear that you're in emotional pain. I'm really sure that we can get through this together. I'm with you. I've got your back. And we're going to find out. I know there's lots of things that can help, and we're going to find out what they are, and we're going to get them. Hope.
Professor Anthony Jorm, Tony, and your lovely wife Betty, how are you today?
Really good. It's a wonderful sunny day here in Coffs Harbour.
All is good. Thank you.
Thank you. It's an honor and privilege from my end, and thank you, both of you. I mean, I was searching for the word. Definitely, Tony is a father figure. Betty, you are a mother figure. I should say you are a parent figure in Australian mental health first aid program. 25 years ago, you were walking with your dogs, and just a very normal question, which is, we have physical first aid. Why don't we have mental first aid? From that basic conversation, now, after 25 years, more than 8 million people worldwide, 40 different countries, people got this training. I would like to know the next stories, because there are a lot of hardships, there are a lot of talking to the wall, how that whole thing actually shaped in 2000 when you launched this program.
I think there's also a background to that conversation, because people usually don't walk their dog and start talking about having a mental health first aid course. It's a very unusual conversation. And let me tell you why we had that conversation. So the first thing is Betty's life experience, so she can tell you about that when she was an adolescent.
I had my first episode of severe depression as a teenager. I was around 14, 15 at high school. I grew up in Sydney. I didn't know it was depression. I thought that I was going a bit crazy. I was different. I was inadequate. My mother gave me a note to take to the principal, apologizing on my behalf for my poor behavior and not partaking of my studies. So that just added to the guilt, which is often part of being depressed. You feel guilty for everything. And often if you do have an episode of depression when you're quite young, it is on the cards that you may then have subsequent episodes, which I did. We now know that if you can nip that first episode in the bud and get better as quickly as possible with a lot of support and help and good learning skills, you may not then go on to have another episode. But I did go on to have episodes in my adult life also. And I'm very lucky to have had Tony as my very best friend right through it all, because a mental illness can make or break relationships. And I was so lucky he stuck with me. Thank you, Tony.
Well, it made it in our case. It's been wonderful having Betty as my best friend and spending my life with her. That's what Betty brought to the conversation. She also brought something else we'll come to in a minute. But what I brought to the conversation, I was a researcher at the Australian National University, and I was doing some research on communities' understanding about mental health problems, what we call mental health literacy. We found that rather poor understanding, or some big gulfs in understanding between what professionals thought about mental health problems and what the public thought. And I was thinking about ways that you could reduce that gap. And I went to this symposium where they had we broke out into discussion groups. And I was in this discussion group, and one of the people there was a person I had known for some years, Meg Smith, who had a history of bipolar disorder. And she said, what we need is a depression first aid. Wow, that's a really great idea, depression first aid. So on the dog walk, I said to Betty, I had this conversation and Meg Smith used this phrase, depression first aid. And I said, Betty, you teach first aid. So tell us about that, Betty.
Yes, I have been a school teacher, and I've also been a community diabetes educator. But when Tony told me that, I also, in my spare time, probably weekends or evenings, I taught regular first aid with Red Cross in Canberra. And it really struck me. I thought, in the Red Cross course that we teach, it may be different now, but this was back in before the turn of the century, we didn't teach anything about mental health problems. And we know how common mental health problems are and how disabling they can be. But we only really learned how to help, someone fell under the bus or went over the cliff or had a heart attack or an asthma attack. We didn't learn anything about the disabling nature of mental health problems. Being someone who's had depression on and off through my life, I immediately felt guilty and thought, I should have known better. I should have known that I should be teaching about mental health. And so that's where we thought, yeah, we maybe can get a little bit into a first aid course about mental health. And we went and had a yarn with the chappie who was the head of the first aid course in Canberra. And he said, maybe you could do a 60-minute slot or something.
Just an add-on to regular first aid.
That people could choose whether they want to do an additional module. And we decided, no, there was too much to cover. So we then set about thinking, let's design our own mental health first aid course. Tony being a researcher and I've done research, we really wanted to be as good as possible and evidence-based as possible.
So when we discussed it, we both decided on the dog, this is a great idea. And our vision was that we'd do this as a community service activity in Canberra, where we lived at that time. And we'd do like 1 or 2 weekend courses a year, nothing to do with our paid work, just as a sort of voluntary activity. So we didn't think very big at all about it all. We talked about it on and off for several years about what we might go in the course, but because we were both really busy, we never got time to do it. And then in the year 2000, Betty worked then at Canberra Hospital, and she reduced her paid working hours, and she did 1 day a week as a volunteer working on it. And that's when it really got going at that point. And then soon she was able to get a small grant that paid a part salary, and then she went full time on the part salary, and then it just went leaps and bounds in ways we never expected. Like if some genie had come back to that dog walk and said, you know, there'll be all these millions of people in 40 plus countries doing it, no way at all. If it had gone out to some other communities in Australia, we would have thought that was pretty good at the time. So you don't have to have a big ambition. You just start small and see where it leads. Give it a try.
Because I am also working in mental health, many people don't know this concept of engaging community. What is this engaging community means? And Betty, if you would like, you can also answer the questions. Up to you guys.
Okay, engaging community. Well, that's a very broad question. It can mean a lot of things. But I guess as far as our thinking is concerned, is that mental health problems are very common. So from our national survey in Australia done by the Australian Bureau of Statistics, it's about 1 in 5 adults in any year would have a mental health problem at a diagnosable level. In children and adolescents, they're also very common. So all of us, we're either going to be affected ourselves or we're going to have close contact with people who are affected. So it's going to impact our lives directly or indirectly. There's also a limited mental health workforce, and people who work as clinicians in that area, they have a big job for people who have more severe, long-lasting or recurring illnesses. But there are a lot more people that have problems that they can handle. So I guess our view is that everybody needs some basic skill. Everybody is going to have contact, and everybody can play a role. It'll be a very simple role, so that you don't say this is all about going to be solved by training more and more mental health professionals. We say we're going to make things better for people who have mental health problems by having everyone in the community having some supportive skill. Whole of community action is the way we would see it.
After completing, let's say, this mental health first aid course, whatever you designed, what can an ordinary person confidently do for himself or for others that they couldn't do before?
When I taught first aid, which is more for physical problems, I'd often realize that people knew what to do, but they were hesitant to become engaged. You know, people may see a person who's had an accident and they'll just sort of stand around and I think, oh, I don't want to touch the person for whatever reason, I might make it worse, I might get something. In a way, the skills sometimes are known, but people just haven't got the confidence. And I think that's what a first aid course does, is give people, it does give some skills, but it gives people confidence that they can actually go in there and do something. I think the mental health first aid course does also, but I think perhaps it even teaches more skills because, as we've heard, our community hasn't had such good mental health literacy. They just haven't known much about what are mental health problems, why do some people get them, what are the risk factors, what are the best treatments, what can I do to help somebody? And that's what we hope, the mental health first aid course would do, is to give people that assurance and that confidence that they can do something and that they don't have to go and solve the problem. It doesn't have to be big, difficult things, but with the right attitude and the right knowledge, they can be helpful. In the mental health first aid course, we have an action plan, just like regular first aid has an action plan of DRABC, which a lot of people would know. We have ALGEE, which we call algae, and we even have a mascot, a koala called Algae, to help us remember this acronym. So A is approach and assess and assist with any crises. L is listen non-judgmentally. ALG, G is give support and information. ALGEE is encourage appropriate professional help. And the last E is encourage other supports. So once people know, well, what are the evidence-based other supports I can give? Who should I be looking to for professional help? Who should I be recommending? How do I give support and information? It's not giving advice or telling someone what to do, but the really important action is that second one, L. Listen non-judgmentally. It really is important. Listen and talk to the person without judging them as being silly or having a problem that they could have fixed up. They really do have something that's distressing for them. Don't judge them. Listen and be as helpful as you can. That's what I hope people would take away from the course. Tony, would you like to add anything to that?
Yeah, you covered that very thoroughly, Betty. But when Betty came up with the action plan, it all seemed very sensible to us. But we thought, well, how do we know they were the best actions to do? What we did was we asked various individual experts or people who had personal experience and followed their advice to some degree, but we realized that's not good enough. We needed a more thorough basis for what people were taught to do. So what we wondered then was, well, when you do a physical first aid course with St. John or Red Cross, how do they know to do DRABC? How do you know how to do CPR? And we found that they had these international guidelines that were developed by an organisation called ILCOR, ILCOR, and then various first aid organisations teach according to those guidelines. So we thought, okay, we need similar international guidelines of mental health first aid. And then we worked for years to develop these guidelines. And because you can't do sort of like, experiments or clinical trials on first aid strategies, you can't say, well, you come across someone that's suicidal on a random basis, you do this and someone else do something else and we'll see what the outcome is. You can't do that practically or ethically. So we thought the best evidence you're going to get is people who've done these things, who've given support or received support. So we got expert panels who are professionals in the area and also expert panels of people who had personal experience and have become advocates in the area. And what we got is the high level of a consensus of both those groups. So everything that was taught in the course, you say, well, why did you teach that? It wasn't our opinion. Might have been our opinion, but that wasn't the reason it was in there. It was in there because we had this international panel, professionals and people with personal experience who have become advocates, who said at a high level, this is what should be done. So I think that gave us a very strong basis. And I think it also, we were, I think, pretty early on in the work we were doing, valuing the role of personal experience or lived experience, many people call it, as a source of expertise to guide what is taught.
Many still don't know the concept of burden of disease. Okay, there are some dollar value you can see here and there. We know there is a problem with productivity, quality of life got bad and all these things. So please explain with some current data or the extended problem what we are dealing because of this mental health.
Well, traditionally in Australia and other countries, if you wanted to evaluate what are the biggest health problems in the country, what people looked at was mortality statistics. Because when somebody dies, a doctor writes a cause of death, and over a century in Australia, we've been compiling those causes of death, and you could say, well, what are the things that kill people? And there are things like cancer and heart disease, in the distant past, infectious diseases. But what that doesn't take account is the things that really disrupt a person's life, but don't necessarily shorten their life. So you can think of physical diseases, things like arthritis or chronic pain, which can have a very disruptive effect, but it won't necessarily shorten a person's life. And that's the case for mental illnesses as well. They can kill people, but primarily they disrupt the person's ability to do fulfill their goals in life. To work, to have satisfying relationships, to function in the way they want to function. And the other big difference is that the killer diseases like cancer and heart disease, they basically mainly affect old people. They can affect people at any age. Young children can be affected by them and die. But they're primarily, the incidence goes up dramatically with age. They primarily affect old people. But with mental illnesses, it's exactly the opposite pattern. So it primarily affect younger people. They often have adolescence as a starting point or during youth, sometimes during childhood. And people can have this sort of relapsing course where they have an episode, but then they might get better. And then later in life, they have another episode, which was what happened with Betty. So because this disrupting effect on life and the early start, it can have quite an impact, but mortality statistics don't show that. So in the 1990s, two people, Murray and Lopez, came up with this idea of looking at what they call disability adjusted life years, very technical stuff. When they looked at both years of life that people had lost through premature death and the years of life they lived with disability, and they put them together, mental illnesses came up as a major health problem. They are the biggest source of disability, but not the biggest source of mortality. And as time has gone on, now there have been more and more repetitions of this global burden of disease work, and mental illnesses are becoming more and more prominent. The incidence of cancer and heart disease go down. We're getting these disabling problems like mental health problems. And the big one is depression. People hadn't realized that. It is a huge source of disability in the population. So people are realizing we've got to give more attention to mental health problems in our health system, and increasingly people are realizing our preventive system as well. And again, this is a reason why everybody needs mental health first aid skills, because they do have this whole impact, and it's not, the health system is not the total solution by any means. It's something where we all need to play a role.
And because, Tony, you are working in this community space, and Betty, you are teaching to a lot of people in the community, why do some communities naturally support vulnerable people while others leave people isolated? Is it what? Awareness, resource, culture, adequate support? I mean, is there any strong main reason behind it? I mean, we Indians, we are not very good in it. That's why I'm asking it very generally.
I'll start off and see what Betty says later, but I think there are major differences in stigma between different cultures. And certainly because I'm 75, so I can talk about my lifespan, but the stigma of mental health problems in Australia, I think, has dramatically decreased since I was a young adult. Certainly for things like depression, anxiety disorders. For other health problems like psychotic disorders like schizophrenia, not so much. I think that's still a big issue there. And in some cultures, South Asian, East Asian cultures, stigma can be a bigger problem. It can be seen as a shame on the family if anybody finds out. So people want to keep the problem confined within family members and more likely to keep it a secret. Poorer countries, there isn't a good social welfare system. You are really dependent on your family to support you if you've got a severe mental illness, for example. And if there's a breakdown in that family relationship, you can end up living on the street. And I've certainly seen that occurring with people with severe mental illnesses in some countries. We certainly have homeless people with mental illness in Australia too, but you see it much more severely in those countries, because without the family support, there isn't the same degree of welfare system we're fortunate to have in Australia that can pick up the gap and help support the person. But also there is the level of skill too. There are various taboos. Like I think one that Betty and I have often discussed is the taboo of talking about suicidal thoughts. I mean, that's been a big taboo in Australia and continues to be. People are reluctant to do it. And I think in some cultural groups, where it seemed to be a sinful thing, people can judge it very negatively. So people can't talk about suicidal thoughts. It makes it very difficult for them to let others know how they're feeling and to get support, for example.
That's very comprehensive. Thanks, Tony. I think also, the influence of the government and policies in education. I know here in Australia that there's much more information now and teaching given in primary school and high school around mental illness. And I think mental health awareness and less stigma is certainly prominent now amongst our younger people. And that's because of educational policies that have been adopted.
Yeah, I think that's a good point. I mean, I think Betty and I could speak as older people that, younger people are much more willing to talk openly than our generation was. And Betty was talking about work in schools. I think of our colleagues, Laura Hart and Claire Kelly, who developed teen mental health first aid, which is for high school students, and how to be supportive to a friend. So starting very early and learning those skills, because we know, teenagers, if they have mental health problems, they aren't necessarily going to talk to a school counsellor or their parents. They talk to their friend. The friend isn't necessarily the best equipped person to deal with it, but they're going to have to. So you have to give them some basic skills and how to be a good friend, but also to connect their friend to a responsible adult who can really take more responsibility. So, there are other programs of that sort, which weren't around at all before. And I think for other cultures and other parts of the world, those things are probably still developing. A lot more could be done.
As definitely the younger generations are much better and open about it, but because of the changing social fabric and changing our societal structure, loneliness and death of despair is also kind of going to the roof. How you see that, or is there any program you are thinking about it for the old age people?
It's very hard to measure those things, when we say, oh, the good old days, or, oh, people are more lonely or, on their own or whatever. Now, I'm not sure very clear-cut evidence is on that. And Tony, you might like to comment on that if you know.
Well, we didn't do surveys way back when, so you look
Yes.
at when we have surveys on these things, and it's really this century, you can, look at trends about mental health or things like loneliness. So, it's quite speculation that things were better in the past, though there's certainly data that with adolescents or young people more generally, over the last decade or so, things seem to have got worse. And during the COVID period, the lockdown period, things seem to have got worse during that period particularly. In Australia, we've had a lot of discussion about social media. It's not quite clear how important that is, but certainly COVID lockdowns had an effect. And I know with some of the colleagues I work with academically, there's been a lot of concern about school refusal, like kids who are off school. Like Betty and I were living in Melbourne during most of the COVID period, and people were locked down, not able to go to school for basically most of 2 years. A very important developmental period. And then when schools open up, they're not socially developed. They get anxious about going to school. And, there's this sort of epidemic of school refusal fueled by anxiety that's happened. So there are these broader social forces that can make things worse, as well as social forces like greater understanding and reductions in stigma and first aid skills that can make things better as well.
When I stepped down as CEO of Mental Health First Aid Australia, I then worked on developing an older person mental health first aid course. So we've now got mental health first aid courses that go across the lifespan. As Tony said, there's one for kids in high school, junior high and senior high. And then there's the one that's for adults helping adults. Oh, and then we had the one, youth mental health first aid, which is adults who work with teenagers, so teachers, sports coaches, all those sort of people. And then, so I went to the other end of the age range and looked at how do we offer mental health first aid to older people. So people like Tony and I, we're 75, from about 65 years onwards, because often I think if an older person is suffering with depression, troublesome anxiety, drug and alcohol problems, psychosis, or dementia, people might just say, oh, that's just aging, or they're sad because their friends are dying, or, that's just part of the aging process. And it's not necessarily at all. And we do know that depression and anxiety really gets missed in older people, and they don't get the help that is there. Some of it is because of their own stigma, that they are of the older generation where they're not going to talk about it because it might make them look weak, and they wouldn't want to talk to it about the doctor. You only talk about physical things to the doctor. You don't talk about your mood and your emotions. So that's what our course really tries to address, is to make people realise how to see the signs and symptoms of depression or anxiety or other mental health problems in an older person, and all the things that are out there that can help. So, but I think there aren't as many programs now in the mental health area for the older person. Certainly younger people are getting it. And I know some of Tony's colleagues are now working on a wonderful mental health course for primary age children,
There are
supporting.
supporters of adults supporting primary age, like parents
Yes.
and teachers,
Yeah.
school staff and sports coaches, etc. But just hearing Betty talk about, the different groups in society and their capacities in this area, one of the things I think is quite striking in the research we've done with mental first aid is that males on average are not as attuned to mental health issues as females. And when you look at who are the instructors for mental health first aid courses, the people that come forward that want to be instructors much more like to be women. And the people who attend the courses are much more likely to be
Yeah,
women.
that's
And
true.
when we do surveys of mental health first aid skills, women on average, a lot of overlap, but women on average do better. So if you have sort of like opt-in courses where you say, oh, here's a mental health first aid course, you can come along and do this in your spare time, males are much less likely to do it. And I think that is why it's important to have situations where everybody does it, like at school, like all the kids do teen mental health first aid, the boys are going to be there, rather than you wait till later in life when they make a decision whether or not to go into it, and they may decide that's not for them.
We're just jumping a little bit here, but where we are seeing the mental health first aid courses being offered now is often to people while they're training at university. So they may be training to be teachers or nurses or dietitians or physiotherapists or whatever. And it's offered to them as part of their education, which is just wonderful. When Tony and I first developed this course, as Tony said, we thought it would just be 2 or 3 courses a year in Canberra. We'd advertise it in the free local paper. We'd get somewhere to hold it, some free hall or something. And, just anyone in the community could come along. But very much now it's in workplaces, very much. And some workplaces have a mental health first aider along with having a first aider officer. They'll have a mental health first aid officer also. And that's great when it's offered in the workplace because it goes across all the employees and the employers.
Yes, we never really imagined that people training to be health professionals would do this sort of training, or even people who are already health professionals would do it. But that has been a major uptake. And I think it does say something about how common mental health problems are in the clients or patients of people in those professions. The big risks that many people in those professions have themselves, because really a lot of the training is for people to support each other, like medical nursing students to support each other. They can be very stressful courses, and because people are in a professional role, they don't want to be seen as someone sees I'm incompetent, I've got a mental illness, so I'm not competent to practice, so they just keep it to themselves or self-medicate or something. So to be able to bring these things up out in the open and for their colleagues to be supportive rather than judgmental about it, I think is a very important area, but one that we never anticipated at the beginning of it all.
Because now you are giving these training to the normal people, how immigrant population, especially from collective societies like Indians or Pakistani, Bangladeshis, even South Asians, how they are receiving it.
Okay, so here in Australia, for immigrants who have come here, we have had some, the mental health first aid course tailored for some groups. There was a lovely, I've forgotten where she came from, but she developed it for Iraqi refugees.
Yes, correct. I had it for Vietnamese Australians, Chinese
Chinese.
Australians, yeah. So there is certainly the demand there for that. I think the problem we always had though, Betty, was to get funding to develop those specialised courses has always been a challenge, and we were always a bit opportunistic about it. When if an opportunity came, we went for it. But I know there were occasions like we had a lot of interest from communities from the Horn of Africa years ago. It was never possible to get funding to develop something specifically for them.
Also, people probably couldn't pay a fee to attend the course. Instructors work with a lot of autonomy. They're not employed by Mental Health First Aid Australia. They can charge whatever fee they like, and some will have a very sliding scale. So for people who can't pay much, they'll run the course very cheaply. Everyone has to provide a mental health first aid manual that has to be given, though it may be going to come online rather an e-copy rather than a hard copy. So there are some costs involved. So yeah, we used to apply for grants left, right and centre to try and help people to attend the course. However, the course has also gone overseas, so that's not quite immigrants, but it's gone not just to English-speaking countries, it's now going to countries where English is a second language, and there's certainly those cultural differences. It has gone to India. There are 2 mental health organisations that run it in India. I'm no longer connected with Mental Health First Aid Australia. I'm truly retired, and I have just stopped being an instructor. So I haven't got my ear to the ground to know exactly what the latest countries are where the mental health first aid program has been licensed to run.
But I think countries that have had major immigrant cultures like Australia and the United States and Canada, they have all done work to do cultural adaptations for different subcultures within their communities, which I think is very important. And I think you need instructors from those communities. And
Yes.
that's why in the past we've had Vietnamese and Chinese Australian instructors. I think that is very important.
New Zealand course changed, modified one for Pacifica people. Mental health First Aid USA did a Spanish version.
And of course, as Aboriginal and Torres Strait Islander Australia, where it has been possible to get funding for, but where you've got all Aboriginal instructors and guidelines are all culturally informed by Aboriginal people. And again, I think it's very important that the instructors are from the same cultural group rather than outsiders coming in trying to give this information.